It's great to see everybody. Really excited to be able to join you all for this training. I wanted to take a few moments at the top of the call before I introduce our guest, who's just really grateful, has made some time to spend with you all this evening. I haven't been able to talk to the network and our folks on the ground since we launched the Mobilize Recovery process earlier in the month. We're really excited about it. You know, it's going to be something very special this year. There are, two parts to it for those of you that have been able to check out the website. The first part being a national bus tour, which will leave Labor Day weekend from the West Coast, and it will head to the East, and it'll be on the road for about 2.5 weeks. And I wanted to just kind of explain, because a lot of the incoming that I got from folks was, well, why a bus tour? Why are we not all going to Vegas? Is Vegas not happening anymore? What's the deal there? Vegas will be back. Vegas will be back next year. We decided to do a bus tour this year because we really wanted to get as much of the training and education and experience that people have in Vegas out into communities. As a lot of you know who have been to the event in Vegas, it is limited in terms of the amount of people who can go. And it also, for folks who don't want to go, not everybody can get to Vegas. So, the goal was really to break down the barriers for the Mobilize experience and really get into communities as much as possible to bring this experience out to where folks are doing the work and really to shine a light on their communities, on their work, and hopefully complement it with some of the work that we do through the Mobilize Network and Voices and Recovery Advocacy Project. We do plan on announcing the tour schedule and the cities and some of the specific stops right after July 4th. I know a lot of people have submitted requests in, and we are doing our best to accommodate as much as humanly possible, knowing the limitations of getting from one side of the country to the other side in a big bus, but it's going to be something really special, I hope, for each and every one of you. And what I really hope too, and I think our hope, is that we reach even more people and bring them under a tent that just continues to get larger and larger because of all of your work. So thank you for that. I would be remiss if I said don't forget to register for the virtual event as well, because it is 2 parts. We still are going to bring everyone together at the end of September from the 29th through October 1st. It'll be 3 days of community building, learning, a lot of great special guests and workshops that we're bringing in for the virtual piece. You can still register at mobilizerecovery.org, put in your short application. It's very short this year. We're anticipating upwards of 2,000 people that'll join, and we're going to create spaces so that we have smaller groups, and folks who have not been able to work together or meet or learn from each other are going to have the ability to break out into smaller cohorts. And again, this is an attempt, to be able to break down some barriers and bring this to more people who wouldn't have the opportunity to, get to Las Vegas or one specific city during one specific date. And just really excited what we have in store. The schedule, the special guests, all of that will start to get rolled out in announcements over the month of July, starting the week after July 4th. Please make sure to share it with colleagues, people who are kind of interested in this work, interested in getting involved in their communities. Please share it with them, mobilizerecovery.org, and encourage them to sign up. And if you haven't signed up yet, please, please, please do, because we definitely want you to be there. I wanted to just give a couple super brief updates of some great things that have been happening in different state coalitions. The Good Samaritan bill passed in the state of Maine. I see Randy's on here and some of our other coalition members from the state of Maine. Phenomenal work. It's the most expansive Good Samaritan bill that exists in the country right now. And the changes, came about as a result of the recovery community's work in the state of Maine. And there is a lot to be proud of there and a lot to model off of there. So great work in Maine. In Wisconsin, fentanyl test strips are now legal. A lot of our advocates in the state of Wisconsin over the last couple of weeks and months worked really, really hard to get that done. And the governor has signed it into law, and that has now happened. Down in Alabama, there is a ton of work going on around building recovery-friendly faith congregations, which is something I've been super excited to follow, and just really grateful for the great team that we have down there doing this work. Maryland is starting to use, the new film, Tipping the Pain Scale, and having screenings across the state in an effort to engage new people into their work. And Indiana is starting to, plan some in-person events around voter registration and, talking to legislators as we get closer to the election around the issues that are most important to the recovery community. The state of Pennsylvania and our partners in the state of Pennsylvania actually utilize the services and great work of the Opioid Response Network, who I'm going to introduce soon, around some guidance around privacy laws that they were navigating. And they were able to put together a great presentation and learning stream that helped recovery advocates on the ground in Pennsylvania navigate the privacy laws and some of the privacy protections that were subject to change. And Aaron can provide that learning to you all, because I think this is something, that we're facing on the national level, but also facing in each individual state, because each individual state has a version of the national privacy protection laws in place. California, I know Patty's on here. They've set this great goal that they are just storming towards, which is having recovery cafes in every single county in the state of California by the year 2027. Colorado is working on a great initiative to support the ban the box around housing discrimination, which is really exciting. Ohio is working on a day of action on September 13th. And right now they're in the process of organizing a campaign to collect 500 letters to elected officials around that day of action for recovery on September 13th. So, these are just a few of the things that all of you are making happen. And it's just incredible, to watch it and to see it, happening and the success and the progress. Last thing I want to mention before I introduce Catherine and our friends from the Opioid Response Network is that, a few of our RAP members and Inclusivity Caucus members are coming together to create an allyship caucus. They've developed the principles that, we really understand that to become good advocates in this movement, we also have to be really good allies. For anyone who's interested in joining, email Carol Cruz, carol@recoveryvoices.com. I will tell you, I actually am the product of an allyship training program that I went through with Yahoo last year. Carol was a part of it too. It opened my eyes, and was one of the most phenomenal things that I did in 2021. So I would encourage all of you, if you're interested in the Allyship Caucus, just shoot an email to Carol. And as they're developing it, she will be sure to include you in those future meetings. And now I'm going to turn this over to our friends at ORN. Opioid Response Network has been a huge supporter of this movement, a huge supporter of Mobilize Recovery now 2 years in a row. I think the resources that they have to provide to our communities, to our organizations that we work with, It's something that I haven't seen before. And, I've come to learn more and more over the last 2 years, just how valuable this can be to our communities. So I just encourage you to listen to Catherine and what she has to say and what the network does, and really how it can benefit you and your work and your questions and what your organization's needs are. So I'm going to go ahead and pass this, put myself on mute, and I'm going to pass this over to Catherine Cates-Wessel, who's the CEO of the American Academy of Addiction Psychiatry and also the principal investigator for the Opioid Response Network. Catherine, thank you so much for taking time on this Thursday before Memorial Day weekend, and I will turn the floor over to you.
Thank you so much, Ryan. I really, really appreciate it. I'm so excited to see all of you and to work together. A big part of what we are about at the American Academy of Addiction Psychiatry is really about collaboration. So the American Academy of Addiction Psychiatry is a membership organization of psychiatrists that specialize in addictions. But what we're going to talk about tonight is a SAMHSA funded grant that we are the lead organization on. Before I go any further, I also want to acknowledge two of my staff members that are here with us tonight, Nick Canning and Jane Goodgear. They both work with me on outreach and communications. So as Ryan mentioned, I am the Chief Executive Officer for American Academy of Addiction Psychiatry, and I'm the Principal Investigator for the SAMHSA-funded Opioid Response Network. Next slide, please. SAMHSA funded this project to be, and before I forget, everything that we do is free of charge. So anything that you're looking for around training and education, it's free. So just keep that in mind. But it's really about coming to you and meeting your needs at the local level. And it's really about building sustainability and frameworks to help you do what you need to do and help provide opportunities to tap into resources that you wouldn't otherwise have. But again, whatever I'm talking about, it's free of charge and is paid by the federal government. Next slide. So what do? When we first were set up, SAMHSA wanted to have funding to support the single state agencies. And as you know, each state gets a certain amount of money to combat the opioid crisis and now stimulant crisis, but also just substance use disorder issues. And there was funding set for each state. SAMHSA wanted a technical assistance support system in every state and territory in the country. So my organization as a lead put together a large coalition of 42 plus partner organizations. And what was really unique about this, it was normally I would work with treatment with the providers, the prescribers. That's my organization predominantly. But this was to go across the full continuum, prevention, treatment, and recovery and beyond, and to put a large coalition together so we could all bring together what we do collectively and not just one perspective or another. And it really was supposed to focus on state agencies, and we were to respond to the needs of the states. 2 days before we launched the project, we were told by the SAMHSA that we needed to open it up to anybody in the country. So just so you know, we have a framework now within 90 days of funding that we have consultants in every state and every territory in the United States. The first thing we needed to do was to do a needs assessment to find out what states felt they needed. And so we had to accomplish that in the first 60 days. Next slide. So let me tell you about who makes up the Opioid Response Network, because that's really the framework with which we work. And it's really critical because a lot of times, as you know, there's a huge amount of stigma in this field. And particularly in the medical community, we also have to deal with stigma. So who's going to come to an addiction psychiatry group? Not a lot of people, because people don't see in medicine that's a challenging area. So we wanted to network with all of medicine, but also with recovery and prevention and multidisciplinary. So next slide. So each of our partner organizations has been asked to get funding. We provide them funding to provide training and education. We have quite a few recovery groups. We have prevention groups. And we work collectively to help each other to provide the training and education that's needed. Next slide. So just to give you a sampling of the types of organizations we have all across medicine with the American Academy of Family Physicians, we have the American Academy of Pediatrics, we have emergency physicians, we have the American Medical Association, we have the American Heart Association, we have Communities for Anti-Drug Coalitions, or CADCA, we have Faces and Voices of Recovery, we have just a huge number of organizations across the Association of American Indian Physicians. Next slide. And some of the others are, we also brought in judges, the National Judicial College, because this is a multi-pronged issue, and everyone needs education and training. And so we wanted to make sure that we had a lot of the key organizations out there. Next slide. So again, what is our mission and what do we do? Our overall goal is to provide evidence-based education and training through local consultants. So we actually went out and vetted individuals with expertise and experience in the community across the country, and developed, it's almost like a temporary agency where we have staff or consultants we can bring in and match them up to a request that comes into our system. Next slide. So this is really key to me, and I feel very strongly about this. It's like I grew up in the South, and I was taught to work together, to collaborate, to network, to support one another. My family ran family businesses, and we bartered for things. We didn't go out and buy things. You bartered with people, and you shared, and you helped one another. So this is really our approach, and I really feel strongly about it. We build on existing efforts, because there's a lot going on out in the fields in the community. You people are perfect examples of the types of network grassroots efforts that really are changing the way things happen. We want to enhance, refine, and fill gaps. We don't want to compete, we don't want to ignore, but we also want to avoid duplicating or recreating the wheel. I've been in this field of the substance use field for over 30 years. Rarely have we had the funds that we have right now to try to address some of these issues. And rarely have we had the awareness in, actually I have seen a big drop in stigma. There's still a tremendous amount, but it has changed quite a bit. Unfortunately, it's taken a lot of loss of lives, but we do have an opportunity, and I do see there is change. So I think for us is we still want to make sure resources are used wisely and effectively, and we want to work with each other. Next slide. So I'm going to provide just a 2-minute video. This is really quick, but hopefully will explain to you in a short amount of time what it would take me a lot longer to do. So I just want you to hear how we work and what we do. Here, I think you just go next slide. Oop. Didn't go. Okay.
Yeah, it doesn't look like it's showing me a play button.
That's okay. We can share it with everybody and send it out to you. But basically, it gives you an example of the types of things that we've done and how you do it. But I can just walk you through it. So our target audience is anyone. We work with communities. We work with states. We work with individuals. One of our first ever requests came from Rhode Island, where I'm located, and it came from a grandmother. And she had taken custody of her grandchildren because their parents were unable to because of their substance use problem. I think they were actually in prison. So she didn't know what to do. She didn't know where to go to get resources in the community. So she put a TA request in through the Opioid Response Network. And we matched her up with a technology specialist in our community to meet with her and to help her with what she needed around learning how to identify resources. And they actually set up a support system for other grandparents in the same situation. So anybody, and we're going to give you a couple examples of the types of things that we've been working on as well. Next slide. Again, we want to provide education and training that's locally relevant, that's culturally responsive, and tailored to meet the specific needs of you. Not us coming in and telling you what you're not doing right or what you need to do, but truly responding to what you've already identified. And you're the ones out there working, and you know the people, you know the barriers, but you know the strengths. And how can we help you and bring resources or expertise that you might need and don't have the funds to do? Next slide. So today, we have over 40 partner organizations. We have over 800 consultants across prevention, treatment, and recovery. More than 3 million people have been helped through our trainings and events, and nearly 46,000 participants in over 4,000 of our activities. Next slide. So how can we help you help others? And this is how we're kind of structured, just so you have an idea. Like I mentioned earlier, we have the partner organizations and they do training and education, but we also have this TA system where you can go in, put a request, and within 1 business day, someone will get back to you. Some of the things that we do in the way we're structured is we have a leadership organization, which is the American Academy of Addiction Psychiatry, the University of Kansas City Addiction Technology Transfer Center. They're the ones that have the technology specialists in every state. So we work with them. They were already working in the states. Columbia University Department of Psychiatry has a large fellowship program, and they help review, vet all the clinical resources to make sure they're evidence-based and accurate. We have work groups on indigenous communities. We have a stimulants work group, a Black communities, sexuality and gender diversity work group, and then we have a data and evaluation group. We have a stakeholders group that focuses on partners that are interested in looking at law, legal issues, and the relationship between law and medicine. We have a recovery group, and we have a prevention group. So each of our requests go through that you have. Hypothetically, say one of you wants to have somebody come in and speak about stigma, for example, and you don't really know anybody in the community, you don't really have funds to have someone come in. It could be for your local organization, it could be for your parent-teacher association, it could be for your colleagues. You would go to the Opioid Response Network, put in a request, and the technology specialist in your state would contact you within 1 business day. And then we would put you in touch with a consultant that best meets your needs. Our partners all have various activities that they develop in training, like the American Heart Association. That's a good example. They've been working with 15 African-American and Hispanic churches on sharing how naloxone can be useful and helpful. And they do that alongside their smoking cessation courses. So we get a huge number of people to really mainstream this information from an organization that is highly regarded. And then we have various special projects, virtual community coalitions, implementation institutes, where we work with groups about how to build systems to incorporate their work into their everyday practice. We provide continuing education as well. Next slide. The TA request, just to give you an idea of what types of training and education do we do. Next slide. So as we mentioned, some of the most common forms of our TA request are trainings, consultation, and providing you materials. So what types of consultation? One of the biggest things that we have are implementation teams. I'll give you an example of one group that we've worked with. We've worked with a judge in rural Tennessee who wanted to make sure that all 3 FDA approved medications were available in his rural jail. So he actually got the funding to provide the medication. He recruited a sheriff in his community, and he was able to hire a clinician who could provide the medication and access to the local methadone program, but he didn't know how to integrate it or how to come up with workflow or what are the policies and procedures, the real nuts and bolts of moving it to the next level. So he contacted us, and we got an implementation scientist and a team to work with him in the state of Tennessee to walk through what are the barriers they have, how can we help them figure out who's going to transport the client from the prison over to the methadone clinic each day, who's going to set up the rules and kind of guidelines. And so our implementation scientists help them work through the process of putting it in place. And that's a good example of consultation that we do. Next slide. So how it works is, one, like I said, you go to opioidresponsenetwork.org and you submit a request. Submit a training request. The specialist will contact you in 1 business day, and they'll set up a time within the next 3 business days that they'll meet with you and they'll learn a little bit more about what it is that you want, who's your target audience, how can we best meet your needs? Because sometimes people don't really have a clear idea what they want. They just know I had these challenges or barriers. So we have them to sit down and spend time with you on the phone, actually. And then they will meet with their consultants and decide who is the best person to match up, or people. There could be more than one person to meet the needs that you have. Next slide. So what are the most common TA requests that we've gotten thus far? No surprise, people want to know about medications for treating addiction. The clinical folks do, as well as recovery community, prevention. Everybody wants to better understand, how does this work, or why is this a drug for a drug, or what does the data show, or how do I engage a family member to go into consider medications for treatment? Looking at psychosocial interventions, implementation or systems change. How peer workforce development. That's a big part of one of the things we're doing, is trying to cultivate networks of getting the peer workforce working with the medical community. We work with the American College of Emergency Physicians, and a big challenge they had was, how do we know who are the peer recovery groups that we should work with? What do we need to know about them? So a lot of it's breaking down barriers between groups that don't normally talk to each other. And so how can we better help each other understand where we're coming from and to support one another? Next slide. So some examples of the TA requests we've gotten. Maryland, we provided a training for the recovery community on how to create a step down or halfway house for LGBTQ individuals. Tennessee, the judge with the rural community that I mentioned earlier. Alaska, we actually Skype in with Fairbanks, Alaska, on looking at them on two things. One, how to look at building a system of care throughout the city of Fairbanks, Alaska, but we've also been doing some prevention programming for tribal leaders across 42 villages. West Virginia, we've been providing training and resources to a clinic on that provides faith-based community resources. And then Ohio, we provided a certified recovery housing organization with best practices on how to implement peer support services. So that's just a couple of examples of some areas to give you a sense of the types of things that we've been working on across the country. Next slide. Again, overall impact. That's challenging to keep up with, because every time that you treat one person, the effect just broadens out as all the work that you do has so much of an impact on broader groups and individuals. Next slide. Next slide. So our work groups come together because we really want people from the outside of the project to come in and really guide and direct us. And one of the things that we want them to do is helping us to know how we can be more responsive and appropriate in our outreach. An example is the indigenous communities. How do we reach out to tribal communities? How can we be culturally aware and educated about what's important to them, and that we make sure that we have the resources that are appropriate, that they're culturally responsive, and that we have consultants that are trained appropriately. And that's what the work groups are really important for, to help guide us and make sure we are, I say, walking the walk. We're not just checking off a box to say, oh yes, we're helping tribal communities, but we really are learning more about how we have to present our information and really understand their needs. Next slide, please. So the work groups do a variety of things. So they help with general outreach events. They will help us exhibiting. They'll target communities that we need to be reaching out to, how to draw in more consultants that represent their work groups, cultivate partner collaboration, and then marketing for using the data specifically for their communities. Next slide. Next slide. So I'm particularly interested in this. This is an area that I personally have worked in, and I really, really find really key, is that how to cultivate the legal, law, medicine relationships, because too often it's one or the other. People in the medical community, I don't deal with people that have legal problems or law. I don't deal with lawyers or judges, because they're just punitive. They just want to hurt people. And then the judges or the legal people say, oh, I don't want to deal with doctors. They just want to coddle people. So if we don't break down those barriers and have these groups talking to one another and really focusing on the person at hand and what their needs are and how we can work within the different systems to understand and appreciate, but also to be more effective, because so much of it is warehousing of people and not solving the problem. There are medical issues sometimes, but not always. There are legal implications, but not always. And to try to dispel a lot of the stigma, because there's a huge amount of stigma, as you know. So that's a big part of what I'm interested in. A lot of it's around education. I've worked with judges, and I've had judges say, I'm willing to learn about pharmacotherapy, but not as long as it's not methadone. And I'm like, but methadone is pharmacotherapy along with other medications. And then they'll mandate only one type of medication. It's like, you can't do that. That's inappropriate. The data is here that each person is an individual, and each person should be treated as individuals, and their medication or their treatment should be considered individually. So having doctors talking with judges can often change things dramatically. And we've seen a lot of change already in the legal law justice system, but a long way to go. So we developed a resource guide, the green guide in front of you, and we have free copies of this. It's really very comprehensive. It's not just for judges in the legal system, but that's how we frame this. Is all the medical perspectives of what you need about substance use disorder, from prevention and throughout the continuum. How's an agonist medication work? How does an antagonist medication work? So really show the data to understand why people have cravings and what happens when you get a medication, that it's not a drug for a drug. Here's some dispelling some of the language you use. We don't approve of calling people addicts. Now, if a person chooses to call themselves that, that's their choice, but we are trying to encourage people to think of them as people first. A person with a substance use problem, a person with an opioid use disorder, because it is a medical disorder, and we want to think of them as people first. And I think, how do you talk to people in a medical clinic that come in just like you would anybody else? So there's some old things, that characteristics and behaviors we're trying to change. And so everyone is treated with dignity and respect. And so those are the kinds of things that we're trying to get across through that project. The second one is up the top right, is we've brought together a huge number across judges, probation, parole, prosecutors, defense attorneys, police, sheriff, trying to think of the others, all together, and we are working on an anti-stigma campaign. Next slide. And this is called Stand Against Stigma. And hopefully, if you're interested in it, you might want to look at it as well. We kicked this off about probably a couple of weeks ago, and it's to commit to 21 days of daily activities, small things. Choose one resource, do one thing to help you think differently about people with substance use disorders and language and behavior around that. How can we help change the way people talk, how they treat each other, and think about it? And so this group came together with representation across all these national organizations, and they were pushing it out to try to encourage people. You know, one, here's a list of terminology that you should not use. Here's alternatives that you could use. Words matter. Let's think about it. Here's another video you can watch about stigma and the impact it can have. So I thought it was a huge thing just to get those organizations to agree that there is stigma and that there are things that we need to do collectively. And so that was the first project we've been working on together. And now we hope to take it to the next level, branch it out, and have more of medicine working collaboratively with them. Next slide. So one of the things, this is probably a little bit out of order, I apologize. When we first got started and we brought prevention, treatment, and recovery together, that was unique because we normally stay in our own lane. We stay in the medical community, we stay with the providers. I've never really worked with the prevention and the recovery community. It's not that we didn't want to, it's just usually drowning with what we're trying to deal with, trying to get the medical community on. But this new project really forced us and encouraged us, if you will, to work collectively. And I have to say, this has been one of the most enlightening aspects of this project, because it really put us talking to one another and breaking down a lot of barriers. So one of the first things we decided we needed to do is we all need to come together and develop guiding principles across prevention, treatment, and recovery. Because if we're going to work together, we're going to have consultants representing us. We all have to believe in the same things. Now, there are things that we're not going to agree on, and that's fine, but we have to recognize the things that we do agree on. And we wanted to pull out, again, we have them for prevention, treatment, and recovery. Every partner organization has to sign and agree to these guiding principles to be a part of the project. Every consultant that we hire has to go through an orientation process for 8 hours to learn about the ORN, but they all have to agree to the guiding principles, because we feel really strongly that unless you believe in these, then we're not doing what we said we were going to do. So the first one is medications for OUD can support long-term recovery. MAT is a critical part of recovery for many living with OUD, and individuals on MAT should not be discounted as not being in recovery. Peer support workers can offer role model recovery and provide support across the continuum of care. Recovery is holistic and includes an individual's health, home, community, and purpose. Recovery is culturally based and defined by the individual in consultation with their clinician and, when appropriate, family and community. So these are concepts. In the treatment end, it was, addiction is a brain disorder. Relapse is part of the process. Substance use can be prevented. So all the kinds of concepts that we felt based on the background, training and experience that were really critical that we all could be comfortable with. And to me, that was a huge step for the field, broadly for the field of substance use disorder and addiction. So I'm really proud that we were able to work collectively, and we all still, feel very strongly about these guiding principles. Next slide. So joining in with the Mobilize Recovery effort is really, really important for us, because it really builds on the basis of what we're all about. SAMHSA, when they set up this grant, and it's a $32 million grant, it's over 2 years. And like I said, we have consultants in every state and every territory. We do training in Guam, we do it in Samoa, but we do it in Alabama and Mississippi and Wisconsin and wherever. We do it in every state. And it really is about local. And that's what makes me think about the recovery community. And each one of you, you are, the bread and butter of really making change. And I think that's why it's so wonderful that having this opportunity to do this bus tour, stopping at towns across the country, coming together and really mobilizing people to help and support each other. And so we'll have our technology specialists that are in each of the state towns or cities that stops along the way, and they'll be there to provide training, education, share the resources that we have. How can we help you? It's really about each and every one of you. We're not trying to sell anybody on any particular thing except to help you fill gaps, and where you need support, we're here to help you and bring that education and training to the forefront. So we're excited about being a part of this. I call it connecting the dots. What are you doing? What is someone else doing? This is what we have. How can we build a network around it to help each other? Because it's certainly going to take all of us, because it's a very comprehensive and complex problem across all the substances and so forth. So we're very excited about this opportunity and hope that we can help you in the things that you're trying to do on your end. Next slide. Together, we can make a difference, and I'm looking forward to working with you, and so are my team. Thank you.
Catherine, do you have there's a couple of questions. Do you mind if I just read them out to you?
Sure.
Great. So one of them is, do you work with harm reduction organizations?
Yep. In fact, it's a good question. Up until this new administration, before that, we were not allowed to do anything around harm reduction. It was, I don't know, it was not allowed, basically. Now with the new administration, we are. In fact, that's an area that's going to be added to the fourth pillar. So it's prevention, treatment, recovery, and harm reduction will be the fourth pillar. And we're actually bringing in harm reduction organizations to be part of the project as well. And we're going to be doing some training around harm reduction, because like our guiding principles, they have to be modified, and we have to educate. We got some pushback from the prevention groups saying, yeah, well, we're not into harm reduction. I'm like, well, we all need to get educated. we've been doing harm reduction all along. Dispensing naloxone, that's harm reduction. So people's ideas and understandings of what things are, we need to enlighten people. So we are going to be having the harm reduction, a couple of harm reduction organizations coming in, training all of our partner organizations, all of our consultants and staff to make sure we're all clear and have a better understanding of what harm reduction is. So yes.
Great. Another question was from one of our partners that works on, has their own nonprofit and is looking to apply for federal, it looks like federal and state grants, and was wondering if ORN provides any type of guidance or like type of grant writing classes or best practices for emerging NGOs on grant writing.
Yeah, no, we can't do that. We've had people ask us that. That's more like a service. So we can't provide a service in that regard. That gets a little bit tricky. So we're not allowed to do any writing or it had to be directly in treatment or prevention, but we can't help write grants. But people have asked us that.
Great. And another one was regarding substance use disorder and kind of the interdisciplinary huddle system within cardiac surgery. They focus on patient-centered care, and the focus right now is best ways to manage situations where patients use drugs in hospitals, specifically looking for guidance on how to handle drugs being brought in, if there's legal standards, if they should be seized, not seized, and if there is guidance or something like that that can be assistance with.
Yeah, so actually we just today brought in a new partner, Legal Action Center. And so we're hoping they're going to be able to help us more on issues like that. But that would be a perfect example of the kinds of education. We have to do education and training because we can't do policies. So we have to be careful about how we frame this. But if it's around working with somebody to understand what's allowed in their state, what are the issues to be concerned with, what's other states doing. So those are the kinds of things that the Legal Action Center as a partner will help us with. We're also looking to bring in the Hospitalist Association because they work so closely within actually the hospitals and how to better educate those working in the hospitals to better understand, because there's a huge disconnect there as well. So how can we get them more involved? And I think that's a really critical piece, is once you get these groups talking to one another, it really raises awareness amongst them. With the American Medical Association, we have the American Dental Association. So if we can get those groups better understanding and appreciating, it does trickle down across and hopefully more in the policy arena as well about how to handle best practices.
Great. Mickey Rice, great partner of ours in Maine, is asking if they wanted to expand methadone access in Maine, would ORN be able to help with a consult on how they could achieve it?
Yeah, another partner of ours is ATOD, Association for Treatment of Opioid Dependence. They're the ones that run of all the OTPs. So Mark Perino is the president of that. So we have consultants that work in methadone clinics that could give you, kind of their experience or ideas of things that they've done. They can't do it for you, but they can provide some information of things to consider and things to talk about. So yes.
Great. And then question just in terms of issues that are covered or could be covered on ORN, could there be some assistance with getting a financial counseling, training up and running for people in recovery to help them get out of debt, establish credit, things like that?
For us to help generate the funding for that? Is that what you mean?
To help with a training, develop a training for people in early recovery on getting out of debt, financial sustainability.
Yeah, so we have another partner, C4. That would be kind of down their lane. It's because they're really interested in workforce development. And so that would be an area, if they were interested in doing something along those lines, in how could they develop a resource to help provide support in the development of workforce. So that if that's something that they were interested in working with somebody, that's a possibility.
Great. And then Yadale asks, does ORN work with Indigenous Native people in urban areas outside of Native American country.
Yes. In fact, this new round, we are applying frantically right now for the next round of ORN, and they folded in the TOR, the Tribal Opioid Response Grantees, in with the ORN. So there's a huge component that's going to be added on to our project, not only to our grantees, but it really expands across Indigenous people across the country. And we've been doing more and more. We have 2 Indigenous communities organizations working with us, and there's a lot more work going in that direction. So yes.
Great. And does ORN, last question that I have here from another partner in Maine, Stephen Knockwood, is ORN able to help advise on anything regarding medical marijuana assisted treatment within recovery residences?
Right now, SAMHSA has asked us to stay away from cannabis because they haven't taken a position so far. And I can honestly say my organization as a whole is kind of split as well because of the data. It's not quite there. So that's a emerging topic that a lot of people are pushing for, but right now we can't.
Understood. Okay, well, thank you, Catherine. If you just want to maybe give one more time how folks can submit requests to ORN.
Sure. If you go to Opioid Response Network.org, and then once you click on the link, just put in submit a TA request. It's very simple. It's a very brief little thing. You put in, basically where you are, what's your contact, what are you interested in, and then submit it, and the technology specialist will respond back to you.
Excellent. And everybody, we those on the road for the bus tour, you'll get to meet many of the members of the Opioid Response Network team. And thank you for taking the time, Catherine and the ORN team, on today's training. And Garrett will send a copy of this video, because I know there was a lot of interest in the content here, to each of you. And he will also send you the information on how to get your TA requests into ORN. Please, 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 everybody, use this resource. This is what these federal dollars are for. It is to support you. Please reach out to ORN, phenomenal resource and phenomenal partner. And with that, I think we're finished. Thank you, everybody, and have a safe holiday.